It's my pleasure to introduce our distinguished speaker today, Dr. Valsamis. Dr. Valsamis is a proud graduate of SUNY Downstate. She began her journey into neurology with a biochemistry, neurophysiology research fellowship. She then completed a PGY1 internal medicine here before moving to Columbia for her neurology residency, where she was also a chief resident. But like all great minds, she knew there's no place like home. So she returned to SUNY Downstate for a research position in epilepsy, and she never left. We are very happy about that. She's currently chief of neurology at Kings County, and across the street, she's vice chair and professor of clinical neurology and assistant program director for neurology residency. Her research interests include mechanisms of epilepsy, particularly after traumatic brain injury. And she also works on quantitative EEG in COVID, quantitative EEG in TBI, in sleep disruption, and currently has a study on automatic seizure prediction. Because why stop at just treating seizure while you can also predict them? Dr. Valsamis has been an ally, a longtime ally of emergency department, and she has tirelessly worked to establish status epilepticus guidelines for both Kings County and Downstate. In fact, those small laminated status epilepticus guidelines you find in your mailboxes, you can thank Dr. Valsamis for those. And while we credit her for many things, let me be clear, she has absolutely nothing to do with the stroke codes going off every 5 minutes in the ED. She's innocent. So please, with that bad joke, let's give the floor to Dr. Valsamis. Thank you, Dr. Valsamis.
Hi, Sharia. Thank you very much. I see you and some other colleagues here that I worked with for many, many years, both clinically and on research projects, so that we can study and understand what we do. First of all, can you hear me? Okay?
Yes.
Okay, and here is a status card. You're going to see it in the talk. And I was asked today to go over the status epilepticus protocol, which really has taken a lot of effort to really get done. And Shahryar has really been a tremendous help in that. I'm going to be talking today about treatment of convulsive status epilepticus in adults. And the first thing is a basic concept. What is a seizure? And a seizure is an episode of hypersynchronous abnormal excessive firing of neurons. It's kind of a long sentence, but it carries all the parts. Can you see my cursor? Okay, good. So the brain, if you've ever seen an EEG, which really does look like squiggles, has different parts that are doing different things all at the same time. And what happens with a seizure is a group of neurons or the entire brain starts firing together, which is not normal activity to have a large group of neurons or the entire brain doing that. If it's a focal seizure, it's a group of neurons. And if it's generalized seizure, it's the entire brain. There are clinical manifestations, shaking or stiffening of a limb or part of the body is one classic one. And that's an example of a focal motor seizure. Whole body shaking with loss of consciousness, an example of the generalized seizure. A staring spell, which could be either generalized, like an absence seizure, or a focal unaware seizure, another focal seizure. Spasms with whole body stiffening, drop attacks, loss of tone. The spasms and drop attacks only happen in children or infants in the case of spasms. I want to point that out because drop attack is not in the differential of syncope because it only happens in children with developmental delay, multiple seizure types, one of which is just loss of tone. So another important concept is a provoked seizure. And a provoked seizure is a seizure that's caused by something, a factor, that overwhelms the normal homeostatic mechanisms. So things like diffuse brain insults, glucose too high or too low, sodium too high or too low, magnesium too low, calcium too high, a high fever, more often in children, renal failure, much more common than hepatic failure. These are some examples of diffuse problems, and then there are focal problems, such as a local mass or an infection, a focal infection, trauma, stroke, hemorrhage. To treat a provoked seizure, you have to address the provoking factors. You can start to treat with the anti-seizure medications, but unless you get rid of the provoking factor that's still driving the seizure, you are not going to have good results. An unprovoked seizure is a seizure that occurs without provoking factors. And it doesn't always require treatment. A single unprovoked seizure, we have ways of stratifying which ones are likely to recur, in which case we're talking about epilepsy, or which ones are single seizures that are not likely to recur. About 10% of the population will have a single unprovoked seizure, and about 5% of the population will develop epilepsy. So about half the time, it doesn't progress. What is epilepsy? Is the tendency to have recurrent unprovoked seizures. In other words, the seizures happen without the fever, the metabolic disarray, and so on. And that we treat with anti-seizure medications. For today's talk for status epilepticus, how long does a seizure last? Is about 30 seconds to 2 minutes in adults. So most seizures, 90% of seizures are over in 2 minutes. If it's longer than 2 minutes, you're starting to get concerned. Why do they stop? Well, when you have this firing of the neurons, it activates the local neurons, and the neurons that get activated first are interneurons. Interneurons are inhibitory, so it's a firewall. You have this inhibitory surround that usually puts out the fire, that stops the seizure. And you restore the balance between excitation and inhibition that's normally there. Excitation is usually the neurotransmitter glutamate with AMPA and NMDA receptors. And inhibition is predominantly the neurotransmitter GABA with GABA A and GABA B receptors. Status epilepticus, which is what we're going to be talking about today, is simply a seizure that does not stop. So the usual firewalls don't stop the seizure, or some mechanisms are activated which prolong the seizure. And very simplistically, excitation overwhelms inhibition. The International League Against Epilepsy is a society combined both physicians, nurse practitioners predominantly, as well as patient groups, and is very active in research, in clinical terminology, and in patient education and caregiver education. And this is what sort of drives the definitions of status epilepticus. And status epilepticus is a condition resulting from a failure of mechanisms responsible for seizure termination. We call that 5 minutes, T1. Or from the initiation of mechanisms that lead to an abnormally prolonged seizure, which can lead to long-term consequences. That's T2. So I'll talk a little bit more about that later. But these two concepts are important. A working definition is what we use for our protocols and clinically. And it's basically 5 minutes or more of continuous seizure activity is status epilepticus. And another definition is 2 or more seizures without full recovery in between. So those are the two most useful definitions that you'll see used in the ED. The time points are T1, I mentioned 5 minutes, and that's what we use for our definition, and that's the firewall failure, and T2 when long complications ensue, and this is where you have mechanisms that prolonged seizures get started. You may sometimes hear of an earlier definition of 30 minutes. It was basically when patients got to the hospital and had pathologically confirmed brain damage. It is well into T2. It's not what we want to be using. 5 minutes is what we want to be using. So Daniel Lowenstein has done a lot of work on status epilepticus, and his really has the definitive concepts here summarized in this slide, which I borrowed from his paper. And stage 1, so this is staging, it's not quite the T1, but it's staging, is milliseconds to seconds. What's happening as the seizure is getting going is you're getting phosphorylation of proteins, ion channels opening and closing, and neurotransmitter release. Not very different from what the brain usually does as its job. Seconds to minutes later, you're getting receptor trafficking, where you're slowly decreasing the inhibitory GABA receptors, beta 2, beta 3, and gamma 2. And you're increasing NMDA and AMPA, which you'll recall are glutamate. So you're starting to shift just by trafficking, in other words, the receptors hopping in, hopping out, from inhibition to excitation. And then as time progresses, you get neuropeptide expression, and now you're bumping up excitation and calming down inhibition. So things are starting to get going to really prolong the seizure. And these are the mechanisms that are talked about in T2. And then days to weeks, now you get genetic and epigenetic changes with gene expression, methylation of DNA, and regulation of microRNA. So our goal is to intervene as early as possible to stop these processes. We're probably intervening somewhere around step 2 and step 3 with this mechanism. So convulsive status epilepticus is continuous generalized tonic-clonic seizures. It's pretty easy to recognize clinically. You can sometimes have myoclonic, where there are jerks that happen. And convulsive status epilepticus is a life-threatening emergency. You can also have non-convulsive status epilepticus, where a focal part of the brain has a seizure that's not stopping. And there's very little clinical correlate. It's usually seen as altered mental status. There are no convulsions, subtle mental changes, confusion out of it. And it's often picked up much later than convulsive status epilepticus. Sometimes we have patients who've been seizing on and off for months that come in. And at that point, it can be very difficult to ramp down because, as we've mentioned, there have been now some semi-permanent or permanent changes that we have to address. In adults, non-convulsive status epilepticus is usually focal. But it's important to remember that even though there's not much clinical manifestation, the brain is actively seizing. And there was one study that showed brain damage occurring 15 to 30 minutes, again, around that T2 time. In focal status, T1 and T2 are less well-defined. So we tend to think of it as an urgency. It's not an emergency, but you want to keep moving with focal status, non-convulsive status epilepticus. I just want to mention the ISET trial here, which was done to look at the agents to use in status epilepticus. Sharia was the PI for that. And we'll talk about which agents we use later. But we also did a study on using the EEG in the emergency department here at Kings County and found that if you did EEGs on everyone who came in, and Sharia, correct me if I get this wrong, and Rich, if that patients who came in about a third of the time when they had altered mental status, they actually had something actionable on the EEG.
Yep.
The epidemiology overall, if you take the entire population, it's about 18.3 to 41 per 100,000. However, there's a bimodal distribution. With seizures, there's a bimodal distribution, more in early childhood, calming down in the teenage years, and then perking back up again in the 60s, 70s, 80s. In the early childhood one, it's more developmental problems, inborn errors in metabolism. In the elderly, it's more acquired insults that happen over life. So yes, less than 1 year, that bumps up almost tenfold to 135 to 155 per 100,000. And over age 60, it's 86 per 100,000. People with epilepsy who have epilepsy as a diagnosis, up to 20% of the children will have status epilepticus, an episode, at least one, and up to 10% of adults will have at least one episode of status epilepticus. So what causes status epilepticus? Again, it varies between children and adults. So starting with adults, and the numbers are more than 100% because some people had multiple causes. The most common one is low anti-seizure drug levels. In other words, someone who has epilepsy and either doesn't take the medication for various reasons, or is vomiting it up, or has a problem with absorption, or is started on a new med that interferes with the kinetics. So low anti-seizure drug levels. About 20% stroke, including hemorrhage, or remote brain injury congenital malformations were combined in this study. 15% with alcohol withdrawal, or anoxic brain injury, or metabolic disturbances. Each of those is 15%. 5% is tumor, drug intoxication, infection, idiopathic, about 2.5 from traumatic brain injury, and no febrile seizures in this population of adults. In children, 50% febrile seizures. About 40% had remote brain injury, 20% with those low seizure medications, 10% stroke hemorrhage, and 5% each for drug intoxication, hypoxic brain injury, metabolic disturbances, infection, idiopathic, and no brain neoplasms. So it's a very different etiology that you're dealing with, what's driving the status epilepticus, depending on age. So what are the dangers? Well, most concerning is probably death, which happens about 1 to 3% in children and 10 to 40% in the elderly. So not only are there more status epilepticus in those two populations, but they're both vulnerable. So Permanent brain damage can happen with status epilepticus, impaired cognition. The epilepsy often gets worse if someone has epilepsy to begin with. And in addition, it's easier to develop status epilepticus. In other words, whatever enabled that seizure to get over the firewalls has now been potentiated, and now this person is now more likely to have status epilepticus. So as a consequence, when we manage this patient, we're much more careful when we're changing medications and making sure that we have a much tighter management. You can have, and the causes are direct neuronal damage from seizing and metabolic exhaustion. You can also have microvascular ischemia because these areas, the brain is a demand circulation to a large degree, and you are having areas that are very active and not able to keep up in terms of blood flow, adding things and removing things. You also have other tissue damage, muscle breakdown that can lead to kidney failure. You can have circulatory failure and so on. The longer the seizure, the higher the chance of death and permanent brain damage. And neuronal injury occurs even if there are no motor manifestations. There was a study that was done on paralyzed baboons that demonstrated this, in addition to clinical observations. The factors that affect outcome, the most important factor is the underlying cause that determines what the outcome is in terms of all comers. And I mentioned age also drives a lot of the underlying outcome. I mentioned the mortality information before. The other thing that's important is seizure length. Refractory status epilepticus happens after 2 seizure meds fail and you're into the multi-day with super refractory. The mortality is 23 to 48% in refractory status epilepticus. So it's really important to get in early. This is something that we can affect. We can't do much about our patient's age, but we can certainly get in and treat with effective medications early to get the status epilepticus under control. So time to cessation and response to treatment, people who respond to the initial treatment, 56% respond. 15% of people respond at the other end when they're in the refractory status epilepticus or burnt out or subtle status. In addition to that, hypoxia is important both for seizure cessation, it helps in seizure cessation, and also hypoxia predicts poor outcome, and the metabolic arrangements that are happening as a result of the seizures. Oops, sorry. So our goals of treatment are to stop the brain from seizing as soon as possible, to prevent brain damage, and remember that motor activity cessation does not necessarily mean the seizures have stopped. It's important to support the body to prevent complications. And once you have reached the second phase, and I'll talk to step 3, you need to get an EEG to see what's going on. We'll talk about specific reasons to get an EEG in a moment. In terms of support the body, our protocol starts as does everything else with ABCs, again, to prevent kidney damage and circulatory collapse. So treatment of status epilepticus is protocol driven. We want to be fast. Time as brain works for seizures as well as stroke. It's evidence-based and accurate. So again, the right medications, the right doses, and the right time. It's also standardized. You want it to be standardized so that you don't have to think about the protocol. We want you thinking during the protocol, but not about what you're going to do next. So you know what's coming next. It speeds up accuracy. It speeds up your time to deliver the medications. It improves accuracy. So we standardize this. We standardized this. Our neurology residency program is at Kings County, Downstate, and Maimonides. We have the same protocol at all 3 sites. We also wanted to standardize with all departments at all 3 sites. So we've worked extensively with emergency medicine. We've also worked with critical care and internal medicine. These are the major places. These are the major departments involved in treating status. So when we developed this protocol, we got buy-in from everybody. And we had to make sure everyone was comfortable with the management of status epilepticus. And I think it was really helpful at this point to mention that being part of the ESET trial was very helpful because we were a little bit, well, I was a little bit down that we were struggling so hard to get consensus on how to treat seizures and how to treat status. And it turned out that this was a problem in that trial all over the country. So we had a lot of company in developing standardized approach to treating seizures. And it really has improved things dramatically. It's really nice to see people whipping out their cars and comparing them so that everyone's on the same page as where we are now, what we do next. The other thing that's also important is quality improvement. The first thing we did was a quality project looking at dosing. And the first time we looked at status epilepticus and had steps for all the different steps in the protocol, in 6 months, we got it 100% correct 0% of the time. It was pathetic. Now that we've had the educational initiatives, developed the protocols, it went up right up to 60% and is continuing to improve. And we're going to be studying that again soon to see how we're doing now that we've really established it. The next goal is to be looking at the time. It's faster, we anecdotally know, but we'd like to study it because there are data suggesting that treating within 45 minutes really improves prognosis. And again, we've developed and agreed upon this beforehand. So here is a picture of the card. We color code it for our latest updates. So we're into the dark purple phase. And it's convulsive protocol, status epilepticus protocol in adults. And again, it's at all 3 centers. So the first line, the first thing one does actually is airway, breathing, circulation. Let me move my cursor over there. So airway, breathing, and circulation. It's important to get IV, so heart rate, blood pressure, oxygen, as I mentioned, is very important. Finger stick, because you want to catch glucose abnormalities early on at EKG. And you're going to be monitoring the EKG to make sure that the patient, on a monitor, to make sure the patient is not getting into trouble as things progress. You'd like to get 2 IVs at least, because you don't want to be losing an IV in the middle of an infusion. Blood glucose, if it's less than 70, you're going to be giving both thiamine and D5W, as I'm sure you know. And these are the labs here, the CBC, metabolic panel, calcium, magnesium phosphate, and so on, are things to look for common causes and common derangements. If the patient has a history of epilepsy, we can check for some anti-seizure levels. Not as useful as it used to be because we have lots more meds now and not so many levels. But sometimes it can be helpful. So the first thing, after one has done the ABCs, the next thing is we give benzodiazepines. Now, that's regardless of what was given in the field. So whether or not EMS gave midazolam in the field, which would be great, we give lorazepam 4 milligram IV is our first choice. There are a number of choices here. We just list 2 because the most common ones are lorazepam and midazolam. The reason we prefer lorazepam is it has less fatty redistribution, and it also has first pass metabolism without active metabolites. That means what you see is what you get. So it's a much cleaner drug than the others, especially if you have to give multiple doses. And if the seizures persist after 5 minutes, then you can repeat it again. And you can mix and match. So if the patient does not have IV access at first and you give midazolam, you can do the second dose with lorazepam. Again, you're trying to stop the seizures. What's really important also is that anytime you give the first agent, the benzo, you have to give the next agent. Why? Because the benzodiazepine will wear off and then the seizures will come right back if you haven't been able to stabilize, address, and stop whatever the provoking issues are. So you want to give your second agent and then after 24, 48 hours, make a decision as to what comes next, not with the first agent. So you're going to go right away to the second agent. We have a number of options. The ESSET trial was looking at levetiracetam, fosphenytoin, and valproate, comparing them head-to-head comparison, and they all worked equally well. We prefer levetiracetam because it has fewer interactions, so that's why that comes first. The dosing is 60 mg per kg over 10 minutes, and the maximum of 4.5 milligrams, 4.5 grams, sorry, 4,500 milligrams. You can also use any of the other agents that work equally well. There may be some times where you might want to use one. Fosphenytoin, 20 Ps per kg IV. Lacosamide 400. This was not in the ESSET trial, but there was another status trial with lacosamide. It's available IV and it can be helpful. It was as effective. Phenobarbital from other studies is equally as effective. We tend not to use phenobarbital because of the side effects, but it really does work if we need to. Valproate was part of the ESSET trial. We tend to use it a little bit more in partial focal status because there's more data for it, but it does have a host of side effects. So levetiracetam is the agent of choice. But if someone comes in who is on an anti-seizure med, the first thing you want to do is give them the anti-seizure med if there's a history of non-adherence or any suspicion of that. The reason is is that they have set up a neurotransmitter balance being on the medication. The most common reason, one of the more common reasons, is non-adherence. So if the levels are low, it really works best to restore whatever they've been taking at home and then continue with the status protocol. But if you don't know, levetiracetam is the agent of choice. The next, all right, so I did want to also point out that here we are with the first line is the benzos. The second line is the anti-seizure medications. At this point is when to page neurology. So we want you to be very comfortable giving the ABCs, the first line and the second line, to help with further management if necessary. And here's our handy dandy pagers. Now we're getting into the third line. So notice in terms of timing, we're well into T2. Like these timing are for when you realize their status or when the patient hits the door. If the patient hits the door, in a study that we did around the time of the first TBI epilepsy prevention study that we did many moons ago, it takes people about 40 minutes to get to the ED. So having people come, if they haven't gotten the benzo in the EMS, they're really well into T2 by the time they're here. It's getting better now that more EMSs are having the benzos. So at this point, line 1, line 2, now we're up to the third line, 30 to 60 minutes after they hit the door or you see the seizure. And we have general anesthetics. At this point, we'd like you to call the neuro ICU. And we tend to use propofol, probably because it's convenient. It's very fast on, very fast off. It's a load of 2 mg per kg IV and repeat every 5 minutes up to 5 doses until the seizures stop. Again, this is a protocol that's been agreed on between the ED and the ICU. We had everybody look it over to make sure they were comfortable with this type of management. The maintenance is about 30 to 100 micrograms per kg per minute, depending on when the seizure stopped. And in order to see that the seizure stopped, you certainly have clinically, but you need to have an EEG at this point. And you're titrating to burst suppression. 1 to 3 bursts per second is where you want them to be. You can also use midazolam. Again, patient does need to be intubated. This is the load, 0.2 mg per kg IV, and then again, repeating up to 10 doses until the seizures stop. Here's the maintenance, 0.1 to 2, somewhere in there. And again, you're titrating to burst suppression on the EEG. For ketamine, intubation is optional, depending on the clinical situation, and you adjust the dose by the physician order only. We're getting more comfortable in the ICUs. We may be able to standardize this a bit more. Load 1.5 mg per kg IV. Every 5 minutes can be repeated up to 3 doses until the seizures stop. And a typical maintenance 0.9 to 10 mg per kg per hour. This is 30 to 60 minutes. At this point, it's really management as the NIC or epilepsy attendant. And then again, considering the different anesthetics, we put ketamine in twice because typically it's propofol and midazolam is what's used. The reason we put ketamine later again is that ketamine works outside the synapse. And what happens over time is the synapse is starting to have that receptor modification that I mentioned. And there's some evidence that ketamine is more effective because it's working outside the synapse. So we're starting to use that more and get more confidence both at our center and around the country. And we'll see how that plays out over time. Pentobarbital is now an option. I mean, one can use it earlier. It's a bit more difficult. It takes a little bit longer to get someone into a pentabarb coma, but it is very effective at stopping status epilepticus and refractory status epilepticus, which is where you are now at this point in the protocol. I want to take a moment. I'll talk about other options in a moment. I do want to say that if we're changing any of the anti-seizure medications, it's very important to cross-titrate or load as indicated. You never want to leave the patient without seizure meds. And if you're transitioning, you want to have a med up to a certain level, bring the next one up, and then bring it down. Again, once someone has had status epilepticus, that's really important. And this was actually part of an RCA that jump-started our quality improvement and developing these protocols. So we're all agreeing on this management. The indications for an EEG. So as I mentioned, if you are at step 3 or further, status continuing beyond 30 minutes, you need to have an EEG to monitor what's going on because you've sedated the patient and you can't follow the motor activity as clinical activity. The other thing is that as things progress, you can get electromechanical dissociation and the brain is still firing away, but the body is no longer responding. So it's very hard to tell what's happening. So the patient needs EEG monitoring. We have continuous EEG monitoring. And we have the ability to put on EEGs 24 hours a day. During the day, it's our EEG technicians. It's a standard EEG. And at night, the neuro ICU is able to put on Cerebells, and other people putting on Cerebells is pretty straightforward. We're getting more and more people trained to do that. We don't like it for long-term managing because it's only 10 electrodes. But in the middle of the night, status yes or no is the indication for Cerebell. In the morning, the tech comes in and we put on a standard EEG where we get the whole brain and we can be much more accurate in figuring out what's going on. We have technicians here 7 days a week. If it's step 3, then a question of absence status or focal unaware, that usually happens. I'd say the most common scenario that we see that is when a patient comes in, has a seizure, and then doesn't wake up. And the question is, are they still seizing or are they just not waking up because they had a lot of benzos, because they're ill or they seized for a long time before? So are they just post-ictal and very sleepy, or are they still seizing with focal unaware status? Absence status is more of an issue, spike wave stupor in children. Then also question of non-epileptic status. We do have people who come in with non-epileptic events, and sometimes the only way to tell is pop an EEG on them. We also, as I mentioned before, you want to monitor the suppression of EEG activity so that you get someone into a coma that's deep enough to calm the seizures down, but not too deep that you start to have more complications managing blood pressure and so on. Okay, so to page the neurology consult resident, we put the information for each hospital and for any urgent EEGs and continuous EEGs. To also page, we work with the EEG techs on getting things done rapidly. Okay, so I just went through that. So special considerations. I mentioned that non-convulsive status epilepticus is usually okay if it's focal unaware, but if it's the end result of status, it's poor prognosis, and that's where the higher mortality numbers kicked in. Focal unaware seizures, I mentioned, are under-recognized. Another study, not ours, was up to 10% with altered mental status and up to 16% of elderly patients with altered mental status. It's also starting to be used in critical care more. It's starting to be appreciated in critical care more. It's one study found 10 to 20 percent of patients in a medical ICU with altered mental status had focal convulsive or non-convulsive status epilepticus. So it's being studied more. We're using EEGs much more commonly in the critical care setting than we had before. Children and infants, we have a separate status protocol for children and a separate one for infants. They're smaller and their livers are not working the same way. The kinetics are very different. So that is developed by our peds neuro colleagues. And we have protocols for both infants and children as well as adults. Status epilepticus in palliative care is another special issue. Status is not comfortable and is not, so controlling status is important. It's just intentional decision-making as to what's appropriate to do in the palliative care setting where you're not going to be intubating people. As I mentioned, focal status epilepticus, another form is epilepsy partialis continua. Some of you may have heard this. It just means focal motor status. It implies a structural lesion and sometimes, again, goes on for a while before someone comes to attention and can be hard to treat. I did want to also point out that in 1995, there was an attack, a sarin attack in Tokyo, in which 13 people died and 5,500 people injured. One of the problems with that toxin was it caused status epilepticus. So it can be a major health problem. Sorry, a major emergency problem. It also can happen in poisoning with antidepressants, stimulants, and antihistamines. So again, these are a form of provoked seizure. So managing the provoking factor is really important. Okay. I mentioned non-epileptic status or pseudo-status epilepticus. Their unusual movements, wax and wane, generalized shaking with preserved consciousness. We can often figure things out clinically, but the gold standard is EEG and epilepsy monitoring for patients with non-epileptic seizures. Okay, I would like to thank Arthur Grant and Catherine Mortati, who really helped develop things at UHB. Ben Cunningham at Maimonides. These are the point people for the status protocol. And Shahryar and his colleagues here at Kings County.